So I have no disclosures, and I'm going to start off with a case, which is sort of representative of many patients who come to our clinic. So Megan is a 28-year-old woman who was referred for evaluation of excessive daytime sleepiness, and she's been experiencing this for years, as far back as her adolescence. And no matter how much sleep she gets, she never feels fully refreshed. And when you talk to her, she tells you that she goes to bed around 11 p.m. to midnight, and she's usually pretty sleepy around then, and she can fall asleep within minutes. Sometimes she wakes up about 3 times per night. It can be a spontaneous awakening, and sometimes she might have trouble falling asleep. Her alarm goes off at 7. She's still a little tired around that time and might hit the snooze a few times, and really finally gets out of bed around 7:30 to 8 a.m. She doesn't take any stimulants or sleep medications. She doesn't report any snoring, gasping. No one's ever said that she stops breathing in her sleep. She uses an average amount of caffeine, about 1 cup of coffee in the morning, sometimes might have a soda with lunch, and drinks only occasionally, a social drink with friends, and denies any use of tobacco or any recreational drug use, and she teaches the 3rd grade. So in terms of her past medical history, it's fairly benign. She has a history of depression that she treats with escitalopram. Otherwise doesn't report any other issues. And on her exam, she's not obese. She is awake, alert, conversant. Her vital signs are normal. And there's no focal deficit seen on her cardiac or pulmonary exam. Her neurological exam is normal as well. And when you look at her oropharynx, you don't see a lot of crowding by her tongue or any excess tissue behind the tongue. And she's got a small neck size. And you ask her to fill out an Epworth sleepiness scale. The scale basically looks at the degree of sleepiness patients have during sedentary activities, 3 being the highest they can rate for each activity. And she scores a total of 18 out of a total of 24 points, indicating a high degree of sleepiness. So what exactly is hypersomnia or excessive daytime sleepiness? Basically, it's the inability to stay awake during the day. Oftentimes patients report an irresistible urge to have to sleep or may unintentionally fall asleep. And you want to make a distinction between that and fatigue. Fatigue is often an exhaustion that people report where they have sort of feel drained of physical or mental energy. These patients may not necessarily report sleepiness when you ask them straight out, but they just don't feel that energy to get off the couch kind of thing. And it's a pretty common problem. In one study, about 12% of referrals over a 22-month period were for hypersomnia. And a poll that was conducted in 2008 showed that about 18% of respondents reported having at least a mild degree of sleepiness with an Epworth sleepiness scale greater than 10. And population studies have also shown a prevalence of daytime sleepiness anywhere from 9 to 26%. So why do we care about excessive daytime sleepiness? And it's because of the consequences that can occur. There can be motor vehicular accidents, occupational accidents. Patients who report a lot of sleepiness can find that their home life or relationships are not working out well because they can't be present and engaged for them. And patients will also report having trouble at school. They're not able to tune in and be focused, and same at work as well too. So you always want to do a thorough evaluation, and part of that really comes down to taking a really good history. So you want to figure out how much sleep do you estimate that this patient is really getting. You want to know what time they go to bed. Are there any delays to falling asleep? Oftentimes distractions like being on your iPad or watching TV can prevent sleep. You also want to find out if they're waking up during the night and why are they waking up. Are they waking up because of anxiety? Are they waking up because of pain or nocturia? And you want to find out what time they're also getting up. You want to know if they're falling asleep during the day, whether it's unintentionally or if these are planned naps. And how much caffeine, alcohol, tobacco, substances in general are they using, because those can disrupt sleep. And ultimately how much people exercise too and what time they're exercising, because late night exercise can also be disruptive to sleep as well. You also want to review their medical history as well. a lot of our medical disorders can also result in fatigue or sleepiness. And so you want to check their cardiac and pulmonary history. Patients with neurological disorders such as Parkinson's disease may also report a lot of sleepiness. It's not uncommon for patients with autoimmune disorders, say such as multiple sclerosis or other autoimmune disorders, including fibromyalgia, may report fatigue. Depression and anxiety are also very closely linked to having difficulties with sleep, poor sleep quality, and experiencing sleepiness during the day. And a lot of medications that we commonly prescribe, such as antidepressants, even beta blockers, pain medication, can result in sleepiness as well. And oftentimes we prescribe sleep medications for patients who say that they can't sleep, but as a consequence, they can also feel like they're unrefreshed during the day, especially if it's not being metabolized well or if they're taking high doses with other medications as well. So on the exam, you want to look for factors that might suggest that patients might have sleep apnea. So as mentioned before, you want to look at tongue and tonsil size. If you're seeing a lot of crowding behind the tongue, do they have a small chin that's displaced posteriorly, retronappia? And if they have a large neck circumference, all these things can point to signs of sleep apnea. You also want to do a cardiac and pulmonary exam because, again, if you find signs of atrial fibrillation, congestive heart failure, wheezing suggesting COPD, these comorbidities can often be seen with sleep disordered breathing, or of themselves also contribute to daytime sleepiness. Neurological exam, like I mentioned, you want to rule out things like whether patients have neuromuscular disorders or other movement disorders. That could signify that patients might have some of these daytime sleepiness or fatigue. And sometimes you need to do some testing for hypothyroidism or diabetes because these two can also contribute to a feeling of lethargy during the day. So this slide shows you a differential diagnosis of reasons for why patients feel sleepy during the day. I think one of the most common reasons is insufficient sleep, and that's why you want to take a really good sleep history. A lot of times you might ask a patient, well, if you're able to get a couple of hours more of sleep, or if you're able to sleep in on the weekends, do you feel more refreshed? And often that answer is very telling. Patients will, if they say that they actually do feel better after extra sleep, it might indicate that they're not getting enough sleep at night. You also want to rule out other sleep disorders, as I mentioned earlier, obstructive sleep apnea, restless leg syndrome, periodic limb movements. All of these can be very disruptive to sleep, and those are things that you want to address independently. Circadian rhythm disorders also can contribute to daytime sleepiness. For example, delayed sleep phase disorder. These patients are the night owls. They like to sleep very late versus conventional times when patients go to bed. And they also will wind up waking up much later in the morning. And for them, if they have to fit their sleep schedule into, say, a traditional work schedule, having to wake up in the morning, they can be shortchanged on sleep and arrive to work feeling very sleepy. So that's something that you need to look out for also. And patients with shift work sleep disorder, if they're having, working the third shift between 11 p.m. to 7 a.m. and having to change shifts on a rotating basis, this can also contribute to poor quality sleep and feeling unrefreshed during the day. Again, you want to rule out the use of sedating medications and other medical disorders, including depression. And narcolepsy and idiopathic hypersomnia are the two topics that I'm going to focus most of this talk on. So getting back to Megan, you discover she's a healthy young woman. Her depression is well managed. She's getting an adequate amount of sleep. She's not taking any sedating medications, and she doesn't fit the profile of someone who has sleep apnea. She's not obese. She's premenopausal, and she doesn't report any snoring or gasping in her sleep. But when you probe a little further, you find out that she has this irresistible urge to fall asleep during the day, affecting her ability to stay awake at work. And on a few occasions, she's woken up spontaneously from sleep and found that she's sort of locked in place where she can't move a muscle. And she doesn't experience any vivid dreams or, getting the sense that something else is in the room when she wakes up out of sleep or on falling asleep. But she does note that, on occasion in the past, when she's told a joke and starts laughing, her knees will buckle, although she hasn't really experienced this for the last couple of years. So in your deferential, you're probably thinking that maybe she has narcolepsy. And narcolepsy is a disorder that affects 1 in 2,000 people. It affects men and women equally. Oftentimes symptoms can actually start in childhood up to early adulthood, but it can take about 5 to 15 years to get a diagnosis. So sometimes there can be a pretty prolonged delay in getting a diagnosis. And there are 2 types of narcolepsy. There's type 1 and type 2. Type 1 is associated with cataplexy versus type 2 is without. So why does it happen? Well, what we know about narcolepsy is, at least with type 1 with cataplexy, that there's a loss of hypocretin that's seen. And these neurons are located in the lateral hypothalamus, and they no longer start producing the hypocretin. With type 2, we're not exactly sure why that's happening. The pathophysiology is unknown. It could be multifactorial. And when we test these patients for hypocretin, some have low hypocretin levels, but some can also have normal levels. A genetic locus called HLA-DQB1602 has been implicated as a possible factor. More than 90% of patients with type 1 narcolepsy will carry this gene. In patients with type 2, it's approximately 50%. However, we know that in the general population, about 12 to 30% carry this gene, so it's not specific to narcolepsy. But carrying this gene can actually increase your risk 200-fold of having narcolepsy. So REM sleep, so narcolepsy is a disorder of REM sleep and regulation. So, what we know about REM sleep, it's associated with rapid eye movements. There is also a loss of muscle tone, we call muscle atonia, with the exception of your eye movement muscles and your diaphragm muscles that assist with breathing. And patients, during REM sleep, this is when we have, that vivid dreaming that we experience. So in patients with narcolepsy, REM sleep actually can occur any time of the day. There's like an intrusion of REM sleep during the daytime. And it's not just confined to just the normal sleep cycle. So narcolepsy is associated with a tetrad of symptoms. So there's the excessive daytime sleepiness. In patients with type 1, they experience the cataplexy. There's sleep paralysis and sleep hallucinations. Now, when patients present for evaluation, they don't always come with all 4 symptoms at once. Only 10 to 15% of patients will have all 4 symptoms on presentation. And daytime sleepiness is one of the first symptoms to present. Typically, it's an acute onset, but it can be gradual. And patients report feeling sleepy despite getting adequate sleep. Patients with narcolepsy will often feel refreshed initially after awakening, or they can feel refreshed even after taking a nap. But this feeling of alertness is often just very short-lived. It doesn't really take care of their sleepiness problem for the day. Cataplexy is a loss of muscle tone triggered by emotion, and that's the key part. So oftentimes, you might hear from a patient that they're told a joke and they start laughing and their knees might buckle or they feel some weakness. Oftentimes it's a positive emotion, although negative emotions like sadness or anger could potentially do that as well too. The paralysis feeling lasts for seconds to a couple of minutes. And oftentimes, patients sort of relate cataplexy to some of the more dramatic YouTube videos that you see where people fall over. And that's not always the case. And I think that's why sometimes cataplexy can be missed. It can be a subtle weakness where people might lose some grip from their hands. They might feel that their face sags. They might feel, their neck go weak and drop their head. They might feel a little buckling around the knees. But sometimes it can evolve into losing muscle tone throughout and can result in falling over. Sleep paralysis is another characteristic of narcolepsy. Basically, patients might experience a loss of muscle tone, sort of a paralysis, really on awakening or falling asleep. And this can be kind of a frightening experience because they're not moving. And it can also be accompanied by sleep hallucinations. These symptoms, though, are not exclusive to narcolepsy. About 20% of the general population will report experiencing one of these. And I like this picture over here because I think this gives you a pretty, it's like a really nice visual representation of what sleep hallucinations and sleep paralysis is. And a lot of times when we ask patients about sleep hallucinations, we ask them if, do you have really vivid dreams? And I sometimes feel like that's probably not the best way of asking it, but really I like the term vivid perceptual experiences. And these are usually visual and there's like frightening content. And patients really truly feel like there's something or someone present in the room with them. But that's not actually there. And we describe sleep hallucinations as being hypnagogic when patients fall asleep and hypnopompic that they experience it on awakening. Patients with narcolepsy will also report having fragmented sleep because, again, there's actually this intrusion of wakefulness during their sleep at night, during nocturnal sleep. In children, they can experience a 20 to 40 pound weight gain. And having narcolepsy doesn't mean that you're immune from having other sleep disorders as well, too. So patients can also have concomitant obstructive sleep apnea, restless leg, periodic limb movements, or even REM behavior disorder. And oftentimes depression is present. So I like this diagram here because it kind of gives you a representation of patient overnight sleep with narcolepsy. And what you see here during REM sleep is actually seen earlier in the night. It's actually in this hypnogram, it's happening on sleep onset. And technically, REM sleep should really be happening about an hour and a half after sleep onset. The other thing that you're seeing here is the fragmented sleep or sleep disruption that's associated with narcolepsy. And you can contrast this to a textbook sleep hypnogram where REM sleep is happening after those 90 minutes after sleep onset. And you have fairly well consolidated sleep with lengthening cycles of REM sleep during the second half of the night. So how do we go about diagnosing narcolepsy? So we do this with a multiple sleep latency test. And basically, we ask patients to do 4 to 5 naps during the daytime. Each nap is 20 minutes each, and they're conducted at 2-hour intervals. And basically what we're looking for is how fast does a patient fall asleep during this nap? And then we average that time over the 4 to 5 naps, what we call the mean sleep latency. The other thing we're looking for during these naps is, does REM sleep appear? Because again, REM sleep is supposed to occur 90 minutes after sleep onset. So if it's occurring during a 20-minute nap, that's abnormal and can be suggestive of narcolepsy. So to get that diagnosis, you're looking to see a mean sleep latency of less than or equal to 8 minutes, indicating a high degree of sleepiness. And you're also looking for more than 2 or more sleep onset REM periods. The only issue with the MSLT is that it can sometimes have a high false positive and a high false negative rate because there can be confounding factors, whether a patient has been getting adequate sleep prior to coming for the study, whether medications were involved. So those things can also affect this outcome of the study. And sometimes you just may not capture it on that particular day for the study. Whenever you run an MSLT, though, you always want to do an overnight sleep study, a polysomnogram the night before. And the reason you do this is that you want to rule out other sleep disorders such as sleep apnea. If that's present, then you don't continue on to the multiple sleep latency test. You have to manage that issue first. The other thing that you're looking for is to make sure the patient got at least a minimum of 6 hours of sleep. The concern is that having less may mean that a patient might look like they have narcolepsy, but it's really not due to narcolepsy, but probably due to insufficient sleep. Ideally, you also want to get a 2-week sleep diary with or without actigraphy. Basically, you're trying to make sure that there is a consistent pattern of getting adequate sleep over time. And the other thing that you instruct patients is that 2 weeks prior to the study, you ask them to, if they can, avoid any hypnotic medications, any sleep medications. You want them to stop any stimulants or any antidepressants because those are REM suppressing meds and they can alter the findings of the study. So what about hypocretin testing? That would seem like the most obvious thing to go to. However, hypocretin testing is invasive, requires obtaining CSF. And sometimes, it is done, and what you're looking for is an absence of hypocretin 1 in the CSF. but there are limitations by insurance. Typically, insurance will not pay for the study. And until recently, I think it was not really even commercially available, though recently I think I saw on Mayo's lab ordering website that they do offer it. So let's just say that you have a patient with excessive daytime sleepiness, you run the MSLT, and you show that there is a lot of sleepiness with a mean sleep latency less than 8 minutes, but you're not capturing those sleep onset REM periods. Oftentimes that patient will receive a diagnosis of idiopathic hypersomnia, especially if they're reporting that they're getting more than 11 hours of sleep and they're still not feeling refreshed. Oftentimes these patients will report that they're taking long naps and still not feeling better afterwards. They may report sleep drunkenness. And when tested, actually, their hypocretin levels are typically normal. Idiopathic hypersomnia is also very similar to narcolepsy in the sense that patients will often report symptoms in adolescence or early 20s. And it's problematic because a lot of times these patients will come in saying that they can't function at work or school. They're having trouble staying focused and being able to complete their tasks. And about 14% of these patients, their symptoms may just remit on their own. But most of the focus on for these patients is really just treatment of the sleepiness. And for these patients, the treatment really revolves around, for narcolepsy patients, is about maintaining wakefulness, treating cataplexy if it's present, consolidating sleep if they're reporting fragmented sleep, and also addressing other sleep disorders. So this table here shows some of the commonly used medications that we use in treating narcolepsy. Oftentimes we go to medications such as modafinil, armodafinil. These are non-amphetamine type stimulants. And the reason we go to these first is because they have a pretty fairly benign side effect profile. For patients where it works, it can work pretty well. You do have to warn patients that there can be a risk of Stevens-Johnson syndrome, and for patients who are on oral contraceptive, it can lower the efficacy of that. But again, that doesn't work for everyone. Sometimes you have to go to more traditional stimulants such as methylphenidate, dexedrine, or Adderall. And for these medications, they can be effective, but you always have to monitor carefully, particularly blood pressure and heart rate, to make sure those are not getting elevated. And then you also have to monitor because there's always the potential risk for abuse with these medications. Sodium oxybate is also used in narcoleptics who report excessive daytime sleepiness. The advantage of this is that it can help consolidate sleep. It's also a controlled substance, and patients have very specific instructions on how to take it. They're instructed to actually take it twice a night, first on going to bed, and then to set an alarm a few hours later to take the second dose to help consolidate their sleep. And this can be pretty effective. And it's actually also used in treating cataplexy as well. So it has two indications, for daytime sleepiness and for treatment of cataplexy. But there are also other medications that are available that we use for cataplexy, primarily medications that suppress REM sleep. And that includes venlafaxine and SSRIs, such as fluoxetine. Clomipramine can be used as well. Another thing that you want to focus on with these patients is also addressing their behavior. So you also want to make sure these patients are engaging in good sleep habits. Telling narcoleptic, we'll try to get a little extra time in sleep may not be very helpful because their sleep is often very fragmented. And in some cases, if it's possible, if it's something that they can fit into their routine or schedule, having them sort of have a short nap, a 15-minute, 20-minute nap, or if they have the possibility of 2 hours, can sometimes help improve their alertness over a few hours and maybe cut down on their use of needing medication. And as with all patients, you always want to warn patients as well about driving and sleepiness. For anyone, whether it's narcolepsy or sleepiness due to any other concerns, at least here in North Carolina, physicians do not have to report. And this can vary from state to state, whether physicians have to report or not. Patients who are looking for a driver's license typically have to report whether they have a sleep disorder, and that's voluntarily reported. And if they do report that, oftentimes they might need to submit a medical evaluation or a statement that their condition is pretty well controlled. So let's get back to Megan. So we did a sleep study on her with a 2-week actigraphy. We asked her to stop her escitalopram for 2 weeks. And what we found is that she's actually getting, she was a pretty good reporter. She was getting to bed at a consistent time, getting adequate sleep. And on the polysomnogram, we didn't see any sleep apnea. She was getting 7.5 hours of sleep, but she did fall asleep within 6 minutes. And her REM onset actually came early at about 60 minutes. And her sleep appeared kind of moderately fragmented. On her MSLT, she showed a mean sleep latency of about 5 minutes. She showed 3 sleep onset REM periods. And also with the testing, we also do urine tox screen to make sure that there are no other substances that can alter the results. For Megan, we treated her with modafinil, and we went up on the dose. This didn't really work for her. And so we switched over to our modafinil, and that actually did improve her symptoms, and she was able to function well at work. And for her cataplexy, it hasn't really been an issue for her for the past 2 years, and this might be because she had been taking the escitalopram during this time, which is a REM suppressing drug. And so that concludes my talk.
Dr. Augustine, excellent talk. First question is a practitioner who works at the VA and sees a high percentage of veterans with obstructive sleep apnea in addition to insomnia and PTSD or PTSD. Is there a correlation in your experience, not directly related to the hypersomnia, but given your background at the VA, perhaps you want to address that?
So you're saying obstructive sleep apnea, insomnia, and PTSD?
Correct.
Yeah, I think, from my experience with these veterans, it's really complicated. And I think you sort of have to take each symptom and try to address them individually. And so you want to treat the sleep apnea if that's present. Sometimes I think that could be a really challenging thing for veterans because a lot of them have difficulty adhering to using CPAP. And you might want to look for other alternative methods of treatment of sleep apnea, such as using an oral appliance and encouraging weight loss for some of them if they're able to. And then also independently addressing their insomnia. I think a lot of times the insomnia and PTSD picture, and also if they're having like mood issues, anxiety disorders, this can also really play a role in how they're feeling sleepy during the day. So you can have someone who actually has their apnea pretty well addressed. But I think all these other issues between the insomnia and mood issues and the PTSD can contribute significantly to that daytime sleepiness. And I think it's really hard to get a hold of that. I think in some cases we do wind up treating with stimulants in that kind of case. In my personal experience with a lot of these patients, I don't know that the stimulants have been very effective. I mean, they still continue to report sleepiness, but right now, if you've addressed all the other factors, that's kind of all we have right now to give them and try to really do a good focus on getting enough sleep at night, because a lot of times they'll report insufficient sleep too.
Okay.
Next one. Do you have a specific way that you ask the question in order to uncover subtle cataplexy symptoms with your patients?
Yeah, I usually try to, ask about more subtle symptoms, and asking about it, I want them to tell me first. Like, I don't want to lead them on with a certain type of question. So I'll ask them, I'll sort of go off with a broad question, like, have you ever experienced any muscle weakness, in the context of an emotion? I'll just keep it broad like that. And depending on what their answer is, and I might probe a little further. Really, I'm just looking for them to tell me what they experience. And usually they might say, well, this is what happens when this occurs, whether it's, I wind up dropping something. One of my favorite anecdotes was I had a patient who told me that whenever he saw his daughter do something cute, his knees would buckle, and he gave the example of stealing a bite of brownie off of his toddler daughter's plate, and she had this surprised look on her face, which hit him as being cute, and then his knees buckled, and I thought that was like a very good example of it.
So I think we're out of time. There's a couple of very interesting questions, very practical ones. Well, why don't you answer this? They're very practical, Dr. Augustine. What do you do if you can't get people off of an antidepressant or a stimulant for 2 weeks in 30 seconds?
Oh, so that's actually a very common thing. And frankly, I will sometimes still run the study potentially, because if you do see those 2 sleep onset REM periods in the setting of a REM suppressing drug, I mean, that to me still says that they probably have, there's a good chance that this person has narcolepsy. In some cases, if it's too dangerous, then we might just say, look, we are going to presume that you have narcolepsy and try to find alternate treatment or try adjusting your medications and see if that helps.
Great. Thank you very much, Dr. Augustine.